Welcome to the deep dive. Today we're taking a closer look at hyperbaric oxygen therapy, HbO2.
Oh, yeah.
Basically breathing pure oxygen in a special pressurized room. It does some, well, pretty amazing things by really boosting oxygen levels in your body.
It's powerful stuff.
But like any powerful treatment, it's good to know about the other side of the coin, the potential side effects, and also just the effects from the pressure itself.
Exactly. Yeah. While the idea of like supercharged oxygen sounds great,
Mm-hmm.
you really need the full picture. We want to go, a bit deeper than the basics and really get into what can actually happen during and after HbO2.
And that's exactly our goal today. It's not about causing alarm, definitely not. It's about equipping you with solid info.
Right. Informed choices.
We're using a chapter from the textbook Hyperbaric Medicine Practice, one that focuses specifically on side effects and complications. So if you're thinking about HbO2, or maybe you're already doing it, or even if you're just curious, knowing about these possibilities is, well, it's key to being properly informed. All right, let's jump right in with something that's actually surprisingly common, ear issues.
Yes. Ear problems. The technical term is otic barotrauma. And it's definitely the most frequent side effect people run into with HbO2.
Otic barotrauma. Okay.
And specifically, middle ear barotrauma, sometimes called barotitis media, that one's consistently cited as the most common medical side effect. Not just for HbO2, but for diving too.
Wow. So it happens a lot then. What are the numbers, like roughly?
Well, that's interesting because the numbers really vary quite a bit between studies. You look back at, say, 1999, one study found about a third of patients reported ear or sinus symptoms.
A third. That's significant.
It is, but interestingly, for many of them, it only happened during their very first treatment. But then, same year, another facility reported much lower rates, like only 2 to 6%.
Huh. Big difference.
Huge difference. And you can find older reports that go way higher, like over 80%. More recently, though, a 2007 study put it at less than 1% per individual treatment, so maybe 0.75 to 0.89%.
Okay, so less than 1% per treatment. That sounds better.
Yeah, and another report from a USAF medical center found an overall rate of 1.3%, with only 0.2% of treatments actually having to be stopped because of it.
So the takeaway is, ear issues are common, maybe especially at first, but the exact chance seems to depend on, well, a lot of things.
That's a good summary.
Let's talk about what's actually going on inside our ears. Why does this happen?
Okay, so think about your ear in three parts. You've got the outer ear, the bit you see that collects sound. Then the middle ear, which is this little air-filled space behind the eardrum that's the bit really sensitive to pressure changes.
Right.
And then the inner ear, which handles the actual hearing and balance. Now, the key player for barotrauma is the middle ear and its connection to the back of your nose and throat.
Ah, the Eustachian tube.
Exactly. That little tube is crucial. Think of it like a tiny pressure valve for your middle ear.
A valve.
It's usually closed, but it opens up, or it should open up when we swallow, yawn, that kind of thing. Its main job is to let air in or out to match the pressure inside your middle ear with the pressure outside.
So it keeps things balanced.
Keeps things balanced, right.
Yeah.
And it also helps drain any fluid that might build up. This ability to open and close, to equalize the pressure, that's what normally protects us from problems when the outside pressure changes, like inside an HbO2 chamber.
Okay, so we get into the chamber, they start increasing the pressure.
Yeah.
What happens then?
So during that compression phase, the pressure outside your eardrum is going up. Ideally, your Eustachian tube opens, lets a little air into the middle ear, and the pressure inside goes up too, matching the outside.
Ideally.
Ideally. But if that tube doesn't open properly, maybe it's a bit sticky or swollen.
Like with a cold?
Exactly, like with a cold or allergies.
Mm.
Then the pressure inside the middle ear stays low while the pressure outside keeps rising. That difference, that imbalance, that's barotrauma, sometimes called a squeeze.
A squeeze. Okay, so the higher outside pressure is literally pushing inwards. What does that feel like?
Yeah, it pushes that thin eardrum inwards. You'll probably start feeling some fullness or pressure first. Then, as the difference gets bigger, maybe around 60 millimeters of mercury difference, it starts to hurt.
60. Okay.
And if it keeps going, say up to around 90 millimeters of mercury difference, it can get really hard, maybe impossible for the Eustachian tube to open at all. That's what people call a locked ear.
Locked ear. That sounds bad.
It's not comfortable.
Yeah.
And interestingly, you don't need a huge pressure change for this to start. Just a few feet of simulated water depth difference, like 2 to 4 feet, can be enough to cause discomfort or lock the ear.
Wow. Really shallow. Okay, so if the pressure keeps increasing and the ear stays locked, What's the worst case scenario?
Well, if that pressure difference keeps building, you can damage the tiny blood vessels in the middle ear lining, causing fluid or even blood to leak into that space.
Bleeding inside the ear.
Yeah, it's basically the body trying to fill the space to equalize the pressure. And in more severe cases, if the pressure difference gets really high, maybe 100 to 500 millimeters of mercury, that's like 4 to 21 feet of seawater depth, the eardrum itself can actually tear or rupture,
Yikes.
which ironically does equalize the pressure instantly, but, having a hole in your eardrum isn't exactly ideal.
Definitely not. You also mentioned something called a reverse squeeze happening during decompression. How's that different?
Right, so reverse squeeze is on the way out of pressure during decompression. Now, the chamber pressure is dropping, so the air trapped inside your middle ear is at a higher pressure than the outside.
Okay, so it needs to get out.
Exactly. Normally, the Eustachian tube just opens passively, lets the excess air out. That's the pop or click you often feel when ascending in a plane. Easy.
Right.
But if the tube is swollen or blocked, maybe with mucus from struggling to clear on the way down.
So the earlier problem makes this worse.
It can, yeah. The higher pressure inside the middle ear can actually push the soft tissues around the tube's opening closed, like pinching it shut from the inside. So the air gets trapped, pressure builds up inside, and that causes pain too.
That sounds really unpleasant. So what are the first things someone would notice if they're getting middle ear barotrauma?
Usually it starts with that feeling of fullness or pressure, then pain. It can become quite sharp as the pressure difference increases.
Okay.
You might also notice your hearing seems a bit muffled in that ear that's conductive hearing loss. And sometimes people get dizzy or feel like the room is spinning. Vertigo.
Vertigo. Why vertigo?
Well, if one ear equalizes fine but the other doesn't, that difference in pressure can mess with the signals coming from your inner ear's balance system. That specific type is called alternobaric vertigo.
Alternobaric. Got it.
Ringing in the ears, tinnitus, that can happen too. And if the eardrum does rupture, the pain actually tends to peak right at that moment, then might ease off a bit.
And a doctor looking inside would see.
They might see redness, maybe some fluid or blood behind the eardrum, or, an actual tear if it's ruptured. There's a scale, the Teed scale, to grade the injury, but really just describing what you see is the best way.
Okay, so clearly we want to avoid this. Prevention sounds key.
Absolutely. Prevention is way better than treatment here. And it really comes down to a few main things.
Like what?
First, teaching patients how to equalize properly before they even go in. Second, trying to identify people who might be at higher risk.
Who's at higher risk?
Anyone with nasal congestion, allergies, a cold, basically anything affecting the nose and throat. Also, a history of ear infections, previous ear surgery, maybe facial trauma. Even things like head and neck radiation treatment can affect the tubes.
Makes sense.
And if someone tells you they always have trouble clearing their ears on airplanes or when diving, that's a big clue they might struggle with HBO2. Oh, and faster compression rates in the chamber definitely increase the risk too.
So slower is generally better if someone's having trouble.
Slower is better, yes.
What specific instructions should people get before going in? How do they equalize?
The key is teaching them several techniques and emphasizing they need to do it early and often, like every 1 or 2 feet of simulated depth change during compression. And crucially, before they feel pain or significant pressure.
Before the pain starts.
Yeah, yes. If they wait until it hurts, it's often too late. The ear might already be locked. They need to know to signal the chamber operator immediately if they feel pain so compression can be stopped.
Okay, what are the techniques?
Well, there's the simple stuff. Yawning widely, maybe pushing your jaw forward as you do it. Swallowing works for many people. Sipping water can help make that easier.
Right.
Some people can learn to kind of tense the muscles in the back of their throat, the soft palate, to pop their ears. There's the Toynbee maneuver. Pinch your nose, close your mouth, and swallow.
Toynbee. Okay.
Then the famous Valsalva.
Okay.
Pinch your nose, close your mouth, and gently try to blow air out through your nose. Gently is the key word here.
Why, Jed?
Because doing it too forcefully can really increase pressure inside your head, intracranial pressure, and there's a small risk of causing problems with the inner ear, like rupturing the round window. So gentle Valsalva.
Good to know. Any others?
Yeah, there's the Frenzel maneuver. It's maybe a bit harder to learn, but very effective and safer. You pinch your nose, close your mouth, close the back of your throat like you're about to lift something heavy, and then use your tongue like a piston to push air up toward the Eustachian tubes.
Frenzel. Sounds complicated.
It takes practice, but divers love it. Sometimes even just tilting your head to one side can help open the tube on the lower side.
Tilting the head. Simple enough to try.
But importantly, all these active maneuvers. Only do them during compression or when the pressure is stable, never during decompression.
Got it. So what's the role of the hyperbaric staff in all this? They're watching the patient.
Absolutely. They need to
Yeah.
be vigilant, looking for any signs of difficulty, grimacing, holding their ears. If a patient signals trouble, stop compression immediately. Hold the pressure steady. Give the patient time to try and equalize. If they have a locked ear, the operator might need to decrease the pressure slightly, maybe just a foot or two to help it open.
Go back up a bit.
Just a tiny bit, yeah. It reduces that pressure difference. And for a reverse squeeze during decompression, they might briefly increase the pressure a little. If someone keeps having issues, definitely slow down the compression or decompression rate for them.
Makes sense.
And critically, don't try to push through it if someone's struggling. Don't just keep increasing the pressure aggressively, because that can cause swelling and make equalization even harder later on.
Right. What about like emergency situations inside the chamber?
In very rare urgent cases, if someone just cannot clear and it's causing severe problems, a physician might need to perform a myringectomy, a tiny cut in the eardrum inside the chamber, but that's really uncommon.
Are there things people can do before starting a course of HBO2 to prevent problems? Longer-term solutions?
Yeah, definitely. For people who know they have persistent equalization problems, or maybe they need a long course of treatment, small ventilation tubes, called PE tubes, can be surgically placed in their eardrums by an ENT doctor.
PE tubes, like kids get for ear infections sometimes.
Exactly like those. They just keep the little pathway open for pressure to equalize automatically. Works very well.
What about medications?
Well, if someone has an acute issue, like a bad cold or sinus infection, it's usually best just to delay their HBO2 treatment until they're better.
Okay.
For chronic stuff like allergies, getting that treated as well as possible before starting HBO2 is a good idea. Using things like nasal steroid sprays regularly might help.
Do decongestants work, like sprays or pills?
It's interesting. Topical sprays like oxymetazoline are often used, but studies haven't really shown they make much difference in preventing barotrauma for HBO2.
Oh, really?
Yeah. Oral decongestants, like pseudoephedrine, did show some benefit in studies with divers, so they might help. But you always have to consider potential side effects and if they're appropriate for the individual patient.
Right. Pseudoephedrine can affect blood pressure and stuff.
Exactly. So it's a case-by-case decision.
And if someone does get middle ear barotrauma, how long do they need to wait before going back for more treatments?
It really depends on the severity. If they had PE tubes put in, they can usually resume pretty quickly. If the eardrum was perforated, they need to wait until it's fully healed or get PE tubes.
And if it was less severe? Just redness or fluid?
For milder cases, there isn't a strict mandatory waiting time. The main thing is the patient has to be able to easily equalize pressure at the surface without pain before they try going back under pressure. If there's still obvious blood or swelling, it's probably wise to wait a bit longer for that to resolve, just to avoid making things worse.
Okay, that covers middle ear pretty thoroughly. No, you mentioned inner ear barotrauma is less common but more serious. Why more serious?
It's more serious because it involves potential damage to the actual structures of the inner ear, the cochlea for hearing, the vestibular system for balance. Specifically, the membranes called the round window and oval window, which separate the fluid-filled inner ear from the air-filled middle ear.
Okay, they're important.
They are. And rupturing these generally takes a bigger pressure difference than rupturing the eardrum. Animal studies suggest the round window might rupture with high internal pressure, like from cerebrospinal fluid, while the eardrum gives way at lower external pressure differences.
So how can these inner ear structures get damaged during HBO2? What's the mechanism?
There are a couple of main ways it could happen. One is if the pressure inside the inner ear fluid becomes much higher than the middle ear pressure. The other is the opposite middle ear pressure gets much higher than inner ear pressure.
How would inner ear pressure get too high?
A really forceful Valsalva maneuver, especially if the Eustachian tube is blocked, can significantly increase pressure inside your skull, the CSF pressure. That pressure transmits to the inner ear fluid. It could potentially push the round window outwards, causing it to rupture into the middle ear space.
Wow, from straining too hard.
Exactly. The other way, high middle ear pressure pushing inwards on the windows, could theoretically happen with a very forceful equalization attempt, or maybe significant overpressure during ascent if the Eustachian tube blocks suddenly. But again, the eardrum is usually the weaker point, so it would likely rupture first, preventing extreme pressure on the inner ear windows.
Okay. What would someone feel if this happened? What are the symptoms of inner ear barotrauma?
The symptoms are usually sudden and quite severe. We're talking profound vertigo, really intense dizziness, loud tinnitus or ringing in the ears, and a significant drop in hearing, often sensorineural hearing loss. It's generally much more dramatic than middle ear symptoms.
Sounds serious.
It is. If you suspect inner ear barotrauma, that person needs to see an ENT specialist, an otolaryngologist, urgently. Prompt evaluation is key.
And what's the treatment?
Treatment is mainly conservative at first. Strict avoidance of anything that increases pressure in the head, no straining, lifting, coughing hard, definitely no more Valsalva attempts. Bed rest, often with the head elevated, is usually recommended.
Any surgery involved?
Sometimes, yes. If there's a confirmed rupture of the round or oval window, surgical exploration and repair might be necessary to patch the leak.
And returning to HBO2 after something like that?
Only after a full recovery and with explicit clearance from the ENT specialist. They might strongly recommend getting PE tubes placed before considering any future hyperbaric exposure to eliminate the need for forceful equalization maneuvers.
Makes sense. Okay, let's quickly touch on the outer ear, external ear barotrauma. You said this is rare in HBO2.
Very rare, yeah. Because the external ear canal is normally wide open to the chamber pressure. So pressure equalizes instantly. The only way you'd get barotrauma there is if the canal is completely blocked, creating a trapped airspace between the blockage and the eardrum.
Blocked by what?
Most commonly, a really solid plug of earwax, CERMIN impaction. Or if someone unwisely wears solid, non-vented earplugs during the treatment. Or possibly severe swelling from an outer ear infection, otitis externa, could potentially seal the canal.
And what happens if it is blocked?
The pressure difference could cause swelling, bruising, or bleeding in the skin of the ear canal. It could potentially traumatize the eardrum, too, from the outside this time.
So prevention is just?
Simple. Don't wear non-vented earplugs. Get regular ear checks if you know you produce a lot of wax. And the staff should always ask about ear symptoms before each treatment.
Easy enough. Now, moving slightly inwards, let's talk sinuses. Paranasal sinus barotrauma, or barosinusitis. Is this basically the same principle as the ears?
It's very similar, yes. We all have these air-filled cavities in our skull, around the nose, the frontal sinuses above the eyes, maxillary in the cheeks, sphenoid deep behind the nose, and ethmoid between the eyes.
Right.
They're lined with mucous membrane, just like your nose, and they connect to the nasal cavity through little openings called ostia. Normally, air passes freely through these ostia, equalizing pressure.
But if those openings get blocked?
Then you've got the same problem as with a blocked Eustachian tube. Inflammation from rhinitis, a cold, allergies, or maybe thick mucus or even nasal polyps can obstruct those ostia.
Okay, so if the sinus opening is blocked during compression,
the pressure inside the sinus stays low while the chamber pressure rises. You get a relative vacuum inside the sinus, a sinus squeeze.
Sinus squeeze. Sounds painful.
It can be very painful, yeah. That negative pressure pulls on the sinus lining, causing swelling, fluid buildup, sometimes bleeding into the sinus.
And during decompression?
If the ostium is blocked, then maybe by swelling caused during compression, the air trapped inside the sinus expands as the chamber pressure drops. Now you have relative overpressure inside the sinus, which also causes pain and pressure.
Can the location of the pain tell you which sinus is involved?
Often, yes, but not always reliably. Frontal sinus pain is typically felt right above the eyebrows, and it can be really intense. That's actually the one most commonly affected in divers, according to studies.
Okay.
Maxillary sinus pain often presents as cheek pain, pressure under the eyes, sometimes even feels like pain in the upper teeth.
Ah, confusing it with a tooth problem, potentially.
Exactly. Sphenoid pain is often harder to pinpoint, maybe felt in the back of the head, top of the skull, sometimes behind the eyes. And ethmoid pain is usually felt between the eyes, over the bridge of the nose, maybe with some eye symptoms too.
Have there been weird symptoms reported, like nerve issues?
There have been some rare reports, mostly from the diving world, of things like facial numbness linked to maxillary sinus barotrauma, probably due to pressure on nearby nerves. It seems less commonly reported specifically during HBO2 therapy, though.
So how do you manage sinus barotrauma, similar to ears?
Pretty similar strategy, yeah. Prevention is key, screening patients for sinus issues, educating them. Using decongestants or nasal steroids might help keep the ostia open, although, again, there isn't specific research proving their effectiveness for HBO2 barotrauma prevention.
Right.
If someone has known chronic sinusitis or polyps, getting the best possible treatment from an ENT or allergist before starting HBO2 is really important.
What if it happens in the chamber? Any emergency treatment?
Not much you can do inside, unfortunately. Maybe try a nasal decongestant spray if available. Slowing down decompression might help if the issue is trapped air expanding. But importantly, if someone develops significant sinus pain during compression, it's usually best to stop the session right there.
Why stop?
Because pushing through the compression pain almost guarantees they'll have swelling and blockage, leading to potentially worse barotrauma from trapped expanding air during the decompression phase. Better to abort and sort out the sinus issue before trying again.
And returning to treatment?
Same as with ears, really.
Hmm.
Wait until the symptoms are completely gone and any underlying sinus condition is treated or managed.
Okay, makes sense. Let's move on to something maybe less expected. Tooth pain. Barodontalgia. That sounds specific.
It is. Barodontalgia, it used to be called aerodontalgia, is simply tooth pain caused by changes in atmospheric pressure.
How does that even happen? Teeth are solid, aren't they?
Mostly solid, yeah. You've got the hard outer enamel, then the dentin underneath, which actually has tiny little fluid-filled tubules. And inside that is the pulp, the living bit, with nerves and blood vessels down in the root.
Okay.
Problems arise usually when there's already something going on with the tooth, like decay, a leaky filling, or inflammation of that pulp tissue called pulpitis. Sometimes after dental work, like a root canal, too.
So what does it feel like? How does the pressure cause pain?
It can be a sharp pain localized to one tooth, or sometimes more of a dull, throbbing ache that's harder to pinpoint. Interestingly, a lot of the older literature is from aviation, reporting pain mostly on ascent, going to lower pressure.
Right.
But a study of French divers found about 7% experienced it, mostly in upper teeth, and for them, it was overwhelmingly during descent going into higher pressure.
Huh. Opposite.
Yeah. Clinically, the dentist might not find much wrong, maybe just some sensitivity when tapping the tooth or blowing air on it. Again, you have to be careful to distinguish it from referred pain from maxillary sinus barotrauma.
Okay, so what's the actual mechanism? Is it trapped air under a filling, expanding, or contracting? That was my first guess.
That was the classic theory for a long time, tiny air bubbles trapped under fillings being squeezed or expanding. But some older experiments where they deliberately put air into teeth didn't reliably cause pain on ascent, kind of challenging that idea.
So maybe not trapped air.
It might play a role sometimes, but the current thinking leans more towards issues with the dental pulp itself, especially if it's already inflamed pulpitis.
How would pulpitis cause pressure pain?
Several theories. Maybe pressure changes affect blood flow to the inflamed pulp, causing pain. Maybe tiny amounts of gas produced by bacteria in an infected pulp expand or contract. Or maybe pressure changes cause fluid to move within those tiny dentinal tubules, especially under leaky fillings, stimulating the nerve endings.
Fluid movement in the tubules. That sounds plausible.
Yeah, one study showed a dye could actually penetrate into dentin under hyperbaric pressure, supporting this idea of fluid shifts. So, sharp pain might be fluid movement in a specific tooth with decay or a bad filling, while dull, diffuse pain is more likely coming from a generally diseased or inflamed pulp.
So it sounds like unhealthy teeth are the main risk factor.
Pretty much. Teeth with untreated decay, failing restorations, or underlying pulp inflammation are the ones most likely to act up under pressure changes.
How do you prevent barodontalgia then?
Mainly through good dental health, especially for people frequently exposed, like hyperbaric staff. Regular dental checkups are important to catch and fix problems like leaky fillings or hidden decay. For patients starting HBO2, especially if they have extensive dental work, maybe a screening panoramic X-ray could be considered.
And if it happens during treatment?
If it's not an urgent HBO2 treatment, it's best to pause the therapy until the person can get a dental evaluation to figure out which tooth is causing the problem and get it treated. Oh, and it's usually advised to avoid pressure changes for a day or two, maybe 3, after having significant dental work done.
Good tip. Okay, let's shift focus completely now to vision. You mentioned vision changes like myopia and cataracts can be linked to HBO2. That sounds a bit worrying.
It can be, yeah, but it's another well-documented effect, known since the late 70s. The main thing we see is a temporary increase in nearsightedness, or myopia. Some people might also experience an acceleration of cataract formation.
Why does that happen? What's the oxygen doing to the eyes?
The exact mechanism isn't fully understood, honestly. It's thought to be related to changes occurring within the lens of the eye due to the high oxygen exposure, maybe affecting the lens proteins or fluid balance.
Okay. Is it permanent?
The good news is the myopia, the nearsightedness, is usually temporary. It tends to resolve on its own within weeks or sometimes months after the HBO2 treatments stop. Cataract progression, however, if it occurs, is generally considered less reversible.
Are some people more likely to get these changes? Any risk factors?
Well, the usual risk factors for cataracts apply here too, things like diabetes, long-term steroid use, previous radiation therapy to the head or neck, lots of UV exposure.
Hmm.
These might increase susceptibility. There's also research looking at antioxidant enzymes in the lens, suggesting oxidative stress from the high oxygen might play a role.
What do the studies show? How common is this, and how bad does it get?
Studies vary. An early one found quite a few patients, especially diabetics, developed myopia after weeks of treatment, but it did eventually recover. A Swedish study involving patients who had a lot of HBO2 sessions, hundreds found almost all developed myopia, and disturbingly, a significant number developed new, irreversible cataracts, some starting after about 150 sessions.
Hundreds of sessions. Okay, that's more than typical.
Much more than typical in the U.S., yeah. A more recent study looking at a standard course, maybe average 26 treatments, found a small average decrease in visual acuity, like reading 1 or 2 lines less on the eye chart. It was a bit more pronounced in older patients and diabetics. And they noticed the myopic shift seemed to plateau around 25 treatments.
So it doesn't necessarily keep getting worse and worse with every single treatment in a standard course.
Apparently not in that study. Another review found most patients, maybe 80%, had some vision change by the 20th treatment, mostly myopia, but some actually became slightly more farsighted. There was one case report of significant cataracts and myopia after only 48 treatments in a younger woman, but that seems unusual for standard protocols.
So the bottom line for a typical course of, say, 20 to 50 treatments?
The bottom line seems to be, new cataracts are rare. Some degree of temporary myopia is relatively common but usually reverses. However, if you start getting into very high numbers of treatments, like over 100, the risk of irreversible changes, including new cataracts, definitely seems to increase.
What should patients be told then, and what should the team do?
Definitely need to inform patients about the possibility of temporary vision changes in the consent form. For people already at high risk for cataracts, maybe consider a baseline eye exam before starting. Advise patients not to rush out and get new glasses mid-treatment, because the prescription will likely change back afterwards.
Wait until things stabilize post-treatment.
Exactly. And if vision changes don't resolve after a reasonable time, say a few months post-treatment, then definitely refer them to an ophthalmologist for a proper evaluation.
Okay. Now let's tackle a more serious, though thankfully less common, complication: seizures. We know high oxygen can affect the brain.
That's right. The link between high-pressure oxygen and seizures goes way back to Paul Bert in the 1870s. It's the classic sign of central nervous system, or CNS, oxygen toxicity.
How often does it actually happen?
Early estimates were around 1 in 10,000 to 12,000 treatments at 2.4 atmospheres pressure with air brakes. More recent reports at similar pressures, like 2.4 or 2.5 ATA for 90 minutes with air brakes, suggest maybe closer to 1 in 2,800 to 1 in 3,700 treatments.
So still rare, but maybe slightly more common than first thought.
Possibly. Although there was one outlier report with a much higher rate, like 1 in 231, but they also controversially suggested the air brakes might be a risk factor, which isn't the general view.
Interesting. Does the pressure level make a big difference?
It seems to, yeah. The risk appears to be significantly lower at 2 atmospheres, maybe 4 or 5 times lower than at 2.4 or 2.5. And one study looking specifically at carbon monoxide poisoning patients found higher seizure rates at 2.8 and 3 ATA compared to 2.45 ATA.
Are certain people or conditions higher risk?
Some conditions seem associated with a slightly higher risk during HBO2, like CO poisoning itself, and maybe acute traumatic arterial insufficiency. Other potential factors could be a history of febrile seizures in childhood, maybe high CO2 levels, like in some COPD patients, narcotic use or withdrawal, alcohol dependence, certain medications.
What about how the oxygen is delivered? Mask versus hood.
There's a suggestion that using a mask might carry a slightly lower risk than a full hood, possibly just because the actual delivered oxygen concentration might be a bit lower with a mask due to potential leaks.
Are there warning signs before a seizure hits? Any prodromal symptoms?
Yes, CNS oxygen toxicity can sometimes cause symptoms before a full seizure. Things like dizziness, twitching, especially facial muscles, nausea, tunnel vision, anxiety, confusion, even ringing in the ears. If a patient reports these, or the staff notices twitching, that's a sign to potentially intervene.
Intervene how?
Usually by taking the patient off 100% oxygen and having them breathe chamber air for a while.
And if a seizure does occur, what kind is it usually, and are there lasting effects?
It's typically a generalized tonic-clonic seizure, what people used to call grand mal, loss of consciousness, muscle rigidity, then jerking movements. The good news is these hyperoxic seizures almost always stop on their own once the oxygen is removed, and they generally don't cause lasting neurological damage.
No long-term problems, usually.
Usually not. One study confirmed patients didn't need long-term anti-seizure meds and had no lasting issues. Some were even able to safely continue HBO2 later without recurrence.
So what's the immediate management protocol if someone seizes in the chamber?
Okay, absolute first step. Get them off the 100% oxygen immediately. Switch them to breathing the air inside the chamber.
Okay, then what? Decompress.
No, critically important, do not decompress the chamber while the seizure is active. Maintain the current pressure
Why not decompress?
because there's a real risk of causing a pulmonary barotrauma and subsequent arterial gas embolism if you rapidly decrease pressure while their airway might be closed during the seizure. There's a case report where that happened with bad results. So hold pressure, switch to air.
Okay, hold pressure, switch to air. How long does the seizure usually last?
Usually just a minute or two once the oxygen is off. After it stops, provide standard post-seizure support, monitor airway, breathing, etc. If the seizure is prolonged or they have another one, then a neurology consult is definitely needed.
Does having one seizure mean they can never have HBO2 again?
Not necessarily. A single hyperoxic seizure doesn't automatically disqualify someone from future treatments, nor does it mean they now have epilepsy. It's a decision made by the hyperbaric physician and the patient, weighing the risks and the continued need for therapy. Resuming treatment is often possible and appropriate.
Good to know. Okay, last major topic, pulmonary barotrauma, specifically pneumothorax, a collapsed lung. You said this is very uncommon with HBO2 itself.
That's right. It's much more associated with diving accidents, particularly rapid ascents. In the context of HBO2, it's very rare. Usually if someone has a pneumothorax, it would be found beforehand and they likely wouldn't get the treatment.
So how could it happen during HBO2?
Theoretically, if someone had existing lung disease, like maybe a bleb or bulla, or perhaps recent chest trauma, the pressure changes could cause trapped air to expand and rupture the lung tissue. Or maybe during decompression, if there was sudden airway obstruction. It's also seen in maybe 5–10% of arterial gas embolism cases, which are themselves rare in standard HBO2.
Remind us quickly what exactly is a pneumothorax.
It's when air leaks into the space between the lung and the chest wall, the pleural space. That air prevents the lung from expanding fully, so it collapses, partially or completely.
And the concern in diving HBO2 is trapped air expanding on ascent.
Exactly. If airways get blocked somehow during ascent, the air in the alveoli expands, potentially rupturing them. This is the main mechanism in diving, less likely with the slow, controlled ascents in HBO2. Other causes exist too, like chest injury, underlying lung disease, or even spontaneous rupture of small blebs.
What are the signs if someone develops one? How would you know?
History and physical exam are key. For a simple pneumothorax, maybe shortness of breath, chest pain, decreased or absent breath sounds on that side. Maybe the chest sounds hollow and tapped. A chest x-ray or CT confirms it.
And a tension pneumothorax, you said that's an emergency.
Yes, tension pneumothorax is life-threatening. Air gets in the pleural space but can't get out, like a one-way valve. Pressure builds rapidly, collapses the lung completely, and pushes the heart and major vessels over, compromising circulation. Acute, severe chest pain, extreme shortness of breath, rapid heart rate, often low blood pressure, low oxygen. Signs might include no breath sounds on one side, distended neck veins, maybe the trachea visibly shifted away from the affected side. You treat this immediately based on suspicion. Don't wait for an x-ray.
How is it managed in a multi-place chamber where staff can get to the patient?
For a small, stable pneumothorax, maybe just observation. For anything significant or a tension pneumothorax, you need to get the air out. A needle decompression can provide immediate relief for tension. Stick a large needle in the chest. Then, usually a chest tube is inserted, which drains the air continuously and allows the lung to reinflate. Sometimes needle aspiration can work for smaller ones. Surgery is for persistent links or recurrent cases.
You mentioned a case series with CO poisoning and CPR.
Yeah, 3 patients receiving HBO2 at 3 ATA for CO poisoning, who also required CPR, developed tension pneumothorax. 2 sadly died. It's hard to say if it was the pneumothorax or the severe CO poisoning or the combination. It just highlights the need for vigilance, especially in critically ill patients. Ultrasound is actually a great tool here, very sensitive for picking up pneumothorax quickly at the bedside, even in the chamber potentially.
What about in a monoplace chamber? No way to stick a needle or tube in there.
That's the major challenge. Management is very different. The strategy relies on manipulating pressure and oxygen. Some reports describe using very slow, controlled decompression, sometimes using specific treatment tables designed for decompression sickness, using high oxygen concentrations to help the trapped air absorb faster, creating a diffusion gradient.
So slow ascent on oxygen.
Essentially, yes. For a suspected tension pneumothorax in a monoplace, stop ascent immediately. If they're really unstable, maybe descend slightly to relieve the tension, then start a very slow ascent, ideally on 100% oxygen using a modified treatment table. The oxygen helps wash out nitrogen from the tissues and creates a gradient to pull the air out of the pleural space.
Even without nitrogen in a 100% oxygen chamber.
The gradient is between the 100% oxygen the patient is breathing, and thus in their blood, and the trapped air in the pleural space, which is mostly nitrogen and oxygen. Breathing pure oxygen maximizes that gradient for absorption of the pleural air. It's about slow, controlled pressure reduction plus high oxygen.
What if it's a dire emergency, like cardiac arrest?
There's at least one report of a trauma patient who arrested with a tension pneumothorax during monoplace HbO2. They performed rapid decompression to get the patient out for immediate chest tube insertion and resuscitation, which was ultimately successful. So, in a true life or death crisis, where immediate access is needed, rapid decompression might be the only, albeit risky, option, assuming immediate post-surfacing care is available.
So prevention and being prepared are critical here, too.
Absolutely. Careful screening, especially for trauma patients. Considering pre-treatment imaging like CT or ultrasound if there's suspicion.
Yeah.
And ensuring staff are well-trained on recognizing pneumothorax and the very different response protocols for multiplace versus monoplace chambers.
Wow. That covers a huge range of potential issues, doesn't it? A really comprehensive look at the side effects and complications of hyperbaric oxygen. It really runs the gamut from, common annoyances like ear popping to these very rare but serious events.
It really does. And I think the key takeaway is, yes, these things can happen, but they're generally understood, they're anticipated, and they're managed by trained professionals as part of providing the therapy. It's like any effective medical treatment. There's always a balance of potential benefits and potential risks.
So it really emphasizes the importance of, well, everything we discussed. Good patient education, careful screening, attentive monitoring during the treatment, and sticking to established safety protocols. That's how you minimize the risks.
Exactly. An informed patient who knows what to potentially expect and feels comfortable communicating any symptoms is crucial. It's a team effort between the patient and the hyperbaric staff.
This has been a fascinating, really deep dive. It certainly makes you appreciate the complex ways that pressure and high oxygen levels interact with our bodies. It kind of makes you wonder, doesn't it? Given all this complexity, what other surprising physiological effects or interactions might we still discover as hyperbaric medicine keeps evolving?
That's a great question to ponder. The body under pressure is still revealing its secrets.
Well, thank you for joining us on the deep dive.